If anything, of course, were to come up, we'd let you know, but we will continue to keep our ear to the ground, so to speak. So, these are just some of the recommendations that we have submitted to the government on who and why we think that this is true in patients with neuromuscular disease. And I have a picture of Peter Gay here. He's the president of NAMDARC, which is the National Association of Medical Directors of Respiratory Care. And he is the one that's gotten together people like myself who are advocates from all over the country to come up with this list. We recommend that full mechanical ventilators be used for anyone who needs more than 8 hours of use, anyone who has demonstrated high CO2 levels or low oxygen levels, especially low oxygen levels that can't be dealt with a regular RAD device, anyone who complains of shortness of breath during the daytime, suggesting that they need SIP ventilation or portability. In neuromuscular disease, if patients are having problems with their speech, and speech is important because talking on the phone or using a speech interface for the internet can be the lifeline for our patients, then we believe that a portable device is important for them to improve their speech. We also use these devices to improve our patients' swallow. They use a portable device with a SIP interface because imagine this, if you want to take a bite of food, what's the first thing that you do? You take a breath in because you know that you are going to have to chew and swallow before you take that next breath. If you run out of air, you're going to take that breath with food in your mouth and it's going to go the wrong direction. We know that if our patients need support for their swallowing, they need to have a portable device they can bring with them to the table. If their lung function is very, very low, they should have a device with battery backup because of safety issues, especially because of issues with unanticipated power loss. And we feel that alarms should be present, either for patients who are young, like our spinal muscular atrophy, which is sort of the pediatric ALS, or in our adults with ALS who may have communication problems and cannot call for their caregivers themselves. And these kinds of alarms are not on regular RAD devices. And so what we have done is given this list of 9 criterion as our submission to the government to say, this is what our neuromuscular patients need, and this is why they need to continue to have access to these devices. So I want to finish up here by giving many thanks to the Les Turner Foundation, for Andrea, for Judy, for everybody up here. We need a new picture because we still have, I know, I got to update my final slide, right? I know, and the Rehabilitation Institute that I work at is going to be the Ability Lab in a mere 10 days, so we got to get that done too. Watch the news. The patient parade is March 25th from the old building to the new one. So I want to thank you guys all for your time and see if you have any questions. Wow, we presented a lot of stuff. Yeah. So we worry about it. I mean, that's one of the reasons why I wanted to finish strongly with our proposal that's already been submitted to Medicare, specifically looking at the needs of patients who have ALS and neuromuscular disease. Our biggest concern is that the guidelines, the way that they stand right now, depending on who interprets them, may have something called the imminent death criterion, in which the government may say, unless you are at risk of imminent death, which they have, I mean, some people have even defined as 4 hours off of a PAP machine, that you're not entitled to a machine. Clearly, we think that's wrong, given everything that I've outlined here, and we have the data and references to go with it in case anyone wants to see that. So am I concerned? Yes, I'm concerned. I'm concerned about it specifically because of the imminent death criterion that has been proposed by some of the leaders within Medicare itself. And so the most that we can be is watchful and advocate And as I keep telling the NAMDARC folks, when they want me to mobilize, I'm mobilizing my people. We're not ready yet. And we have had meetings with the senators who are involved in what's called the COPD caucus, which is a weird term because our patients don't have COPD, but they do advocate for use of all ventilatory equipment. And they understand our issues. They're willing to advocate for us on the Hill, but they've told us not yet. They want to wait for things to get further before we start to push. It is, actually. Oh, thank you for bringing that up. It's very good to see you, by the way. So we did just finish doing a clinical trial looking at the machine that was in the picture here. The clinical trial that we just completed looked at the ability to adjust the machine using a computer interface, both for patency of the upper airway and efficacy of full ventilation. And the machine would do this in real time, making decisions on its own, so that as patients would change in terms of how strong or weak they were, that the machine would do it automatically. And this is a huge issue because there are parts of the country, like I said, in which patients are told, no, if you need any help, you have to go for a full night in a sleep lab. And this software, we are hoping, will allow patients much greater access to equipment, and much greater access to effective settings than we've ever had before. So that study is done, and we are submitted to the FDA, and we're waiting to hear back. Yeah.
Thank you for everything you're doing on behalf of all the ALS patients.
Oh, of course.
Deeply grateful to all that are involved and that care so much. Thank you.
Well, thank you. I appreciate that. All right. Well, this is good. Well, thank you, guys. And you'll have Sherry up here. She'll tell you even more stuff. Okay. Thank you.
Thank you, Dr. Wolf. I think, I have known her for many years, and any time I hear her speak, and I've been doing ALS, let's say 30, so I never cease to learn something from Dr. Wolf. She's just an amazing physician, and I hope you all enjoyed everything that she's had to say as much as I did. So our final speaker is Sherry Dvorak. Sherry has been a respiratory therapist for approximately, 25 years, just a mere babe in the woods. And she is currently now working with a company called Health Technology Resources. Sherry works very closely with our clinic, with the foundation, with our home team, and is totally devoted to working with all of our patients with ALS. She's going to be talking very briefly about and touching on some of the things that Dr. Wolf spoke about, but then I think some of you also saw earlier out in the hallway, there is a table with all the different devices. After Sherry gets done with her little talk, we welcome you to go out there and actually do some hands-on work and demonstration with those machines. And then also, across the hall, we invite you to come over for a brief reception. But first, let's introduce Sherry Dvorak.
All right, so hello. So as Judy said, we're going to just talk briefly in here because I feel it's a little bit more important to get your hands on the masks, hands on the equipment, a little bit more one-on-one question and answers. But definitely, I do want to, go back to what Dr. Wolf said. When we talk about wearing our RADs at night, wearing our masks at night, one thing I want to tell you guys that I tell my personal patients all the time, like Dr. Wolf said, when we sleep, our breathing patterns get more shallow, correct? So one thing I always want you guys to remember is when your butt is in bed, the mask goes on your head. Okay? Anytime you are sleeping, that mask should be on your head. If you're going to nap, take that 20-minute nap, you should wear that mask. Okay? Keep that in your brain. When your butt is in bed, the mask goes on your head. Secondly, all of the therapies that she touched here, and I'm going to touch on at the table outside, your nebulizer treatments, your cough assist therapy, your vest therapy. People sit there and go, there's just not enough time in the day to do all of this. It is so important to do those therapies at least twice a day because we want to prevent any type of pneumonia. We want to prevent that atelectasis, that lung collapse in the lower areas of the lungs, okay? We want to keep the lungs nice and open. We want to prevent those hospitalizations. That is why it is so important to do your therapy every single day, okay? You know, and you want to do your nebulizer first and your vest first, okay? You want a nebulizer, of course. Do we know what nebulizers do? Do y'all know what the purpose of a nebulizer is? Yep, okay, the medications that we do in the nebulizers, the albuterols, the ipratropiums to help open up the airways in the lungs, the saline to help in the secretions, okay? That's the purpose of that. The vest, now we opened everything up. The purpose of the vest is we want to mobilize, right? We opened up those airways, so now let's kind of get that stuff moving around in the lungs. And then, of course, your cough assist is to help hyper-expand the lungs. Again, take those big, deep breaths in, and then help you with that cough to help, you know, get the secretions out. So does anybody have any actual questions on nebulizer, cough assist, vest, breath stacking, anything, like a general question?
Excuse me, it seems like you do the nebulizer and the saline before you put the vest, is that what I'm hearing? 'Cause
Well,
I've been doing it together.
You
In other
can
words,
do
I
it
one
together.
part.
You absolutely can do your
Oh, okay.
nebulizer and vest together.
All right.
And then after that, then you're going to follow with the cough assist.
Right,
Yep,
okay.
yep,
that's the step
absolutely.
I just all of a sudden, I said, oh, I've been doing it wrong.
No, you
Thank
can, you can do the nebulizer and vest together. That can kind of be a teamwork treatment.
Right,
Yep,
right.
followed by your
And
cough
then afterwards, he
assist.
does the saline, but is that correct? He does the nebulizer with the vest, then he does the saline, then he does the cough.
So he does like the albuterol neb.
Albuterol with the vest is what he's wanting to do. Then
Okay.
he is using now the cough assist, then the saline, and then the cough assist again.
Okay.
See, so I think something there, we're not doing the process
Okay,
right.
usually, and we would obviously want to talk with Stephanie and Dr. Wolfer Coleman, but usually we'll go with like the saline if secretions are thick, and then the albuterols if the secretions are thin. You could also kind of interchange, maybe do like one treatment at 8, and then wait a couple of hours, you know, do like your albuterol or, you know, around 8 in the morning, and then wait a couple of hours and do the saline if you are having, you know, issues with the secretions.
Okay, well-
But definitely clarify with doc as to exactly like what meds they want you to take
Okay.
when.
Well, the saline he does only at